Krishna Chaitanya, Professor ENT. I'm here to engage you for today's session, which will be on the clinical discussion about your nose. In my previous sessions, I have been engaging you about clinical sessions on the ear and how it is being taken care. In today's session, I'll be taking care and I will be enlightening you about how to take a case of a nose, if at all it is coming to you, and give a proper reference and give proper first aid to the patient and give it a proper care before you refer it to our higher center. Before I proceed to the session proper, I just want to have all of your feedback and most of you at the end of the session, because some of you were giving your feedback like that some lectures are being a bit fast. If at all you are feeling a bit fast, you can share to me anytime during the session, and we'll be going as much slow as possible to enlighten you maximum about the sessions. Okay, with this brief introduction about the clinical aspects, I just proceed to the proper. As usual, we'll be proceeding with a case. 10-year-old male child was brought to ENT OPD with complaints of nose block, headache for 3 months, with history of sneezes. On examination, there was a fleshy mass seen in the nostril, which is insensitive to touch. What could be the diagnosis? Enumerate the principles of management. So when you are examining the patient, you are seeing a fleshy mass seen through one of the nostrils, and you are seeing signs of inflammation like headache and nose block. This is one case scenario which can be given to you during your clinical sessions. Similarly, another case session or case scenario can be like a female patient came to ENT OPD with complaints of recurrent attacks of sneezes in the morning with headache, again in the morning with copious nasal discharge. Identify the diagnosis and plan appropriate medical management for this patient. So what could it be? So as we proceed through the sessions of today, we will try to find the answers to these two clinical sessions. Okay. So whenever a case of nose comes to you with, you have to be alert to take the history in the following subheadings. Suppose, or elsewise we will consider, suppose a patient has come to you with complaints of nose block, nasal discharge, sneezes, headache, facial pain, trickling or hawking sensation in the throat, bleeding from the nose, snoring, and loss of smell sensation in the nose. You should suspect that there is some pathology involving the nose. So what causes are involved in diagnosis, and how do you diagnose the present disease condition pertaining? We'll be glancing and going through the today and tomorrow sessions. So what is nasal obstruction? Nasal obstruction is something like a block in the nasal cavity. So nasal cavity proper, when it comes to the anatomy, this is your columella of the nose. This is your columella of the nose. These are your nasal vestibules. This is the opening. So whenever you are taking a case, you will be seeing in midline the nasal septum. You are supposed to see a nasal cavity. You are supposed to see the mucosa of the nose and the turbinates in the lateral wall of the nose. So remember, the basic anatomy of the nose will depend on the lateral wall of the nose and the medial wall of the nose or the nasal septum. So medial wall of the nose consists of the nasal septum. Lateral wall of the nose consists of your turbinates and the respective meatus. There are three turbinates: the inferior turbinate, the middle turbinate, and the superior turbinate. Sometimes you also feel a supreme turbinate. There are three major turbinates in the nostril, each nostril in the lateral wall. When it comes to the nasal septum is made up of a cartilage and also the bone. So whenever you are seeing any pathology of the mucosa of the nose, nasal septum, lateral wall of the nose, or the paranasal sinuses, and subsequently involving your nasopharynx, which indirectly again involves your ear and the oropharynx. All these together relate to your nasal complaints itself. So how each clinical symptom presents and what could be the differential diagnosis for each and every clinical symptom based on the age of the patient, based on the sex of the patient, and based on the immune status of the patient will what constitute the present day session. Okay. So whenever each complaint presents to you, you have to evaluate in terms of onset of the clinical symptom. Remember, symptom is something which is told to you by the patient. A clinical symptom is something which is told to you by a patient. A clinical sign is something which is elicited by a clinician. So what the clinician observes and how he, suppose you are pressing somewhere and you are seeing something elsewhere, that could be a sign. That is what we call how you elicit a sign. Suppose the patient comes to you and says, "Sir, I have a nose block, I have a ear pain, I have a throat pain." These are all the clinical symptoms. So this is the basic difference between the symptom and a sign. So whenever the patient comes to you with a clinical symptom, you are supposed to ask the patient in terms of onset of clinical symptom. Onset means how it has originated. Suppose the patient has slept last night, all of a sudden he woke up with something, a pain or an ear or a discharge or nasal obstruction or a bleeding from the nose. That could be of a sudden origin. Suppose there is an immediate trauma and following in trauma, immediately there is a bleed from the nose or there is a change in the shape of the nose. That you call as onset is sudden. Gradual, over a period of time. Suppose if the disease condition is acute, then you are supposed to suspect that the clinical symptoms has originated over a period of less than 1 week or immediately to 1 week. Then you can say that the patient has got an acute symptomatology. Suppose the patient has crossed 1 week and up to a period of 6 weeks, you are supposed to say that the patient is in a subacute phase. Subacute phase. Suppose the patient has the symptoms for more than 6 weeks, then you can suspect that the patient has got chronic symptoms. So chronic symptoms are when you are suspecting a disease process for more than 6 weeks. Today I am going a bit slow because of your, I want each and every one of you to understand the clinical aspects of each and every session. Hence I am going a little bit slow during my clinical sessions. Okay. So let me go through the next aspect, duration. I have covered the duration. I have covered the onset. Again, I have to speak about the progress of the disease. Progress of the disease, suppose the disease has started and it has subsided all of a sudden. Or is it progressing over a period of time? Suppose you have some abscess or swelling of your little finger. Let's think your little finger. You have a swelling here. Today the swelling is of small size. When you see tomorrow, whether this swelling has grown in the size or whether this swelling has come down in the size. So that can be what you call as the progress of the disease. Then comes the resolution. Suppose today there is a swelling. When you see the swelling tomorrow, the swelling has come down. It means the swelling has resolved on its own. That we call it as resolution. Sometimes these swellings, they don't come down in the size. They progress and lead to certain complications. So at that time, the progress can lead to a complication. Okay. So whenever a clinical symptom is being, a history is taken about a clinical symptom, you have to inquire regarding the onset of the symptom. Most of the times during your clinical sessions, we see insidious in origin. What does this term mean? This term means that the patient is not aware. Patient is not aware of when the disease has started. Then you are supposed to use the term insidious in onset. If you are clear how the disease process has evolved, how the disease process has started, then you are supposed to use the either of the terms like sudden in onset or gradually in onset. Most of the times the disease process is sudden in onset. Suppose if there is a predisposing condition, then you can suspect that the disease has a gradual origin. But most of the times, it will not be of insidious in onset. Please remember to not use the word insidious in onset. Only specific places, specific conditions are associated with insidious in onset. Suppose the disease is an iceberg, like a diabetes mellitus. You will not be aware when this diabetes mellitus has started inside our body. That is what we call as insidious. Most of the disease conditions in ENT are sudden in onset. Sometimes certain conditions, they will be predisposed by a previous disease condition. Suppose you are suspecting a sinusitis in a patient that is preceded by allergic rhinitis. So allergic rhinitis will not develop over one day. So that disease condition you call it as gradual. Then the sinusitis develops. This sinusitis again will be gradual. So this is how you are supposed to use the term sudden and gradual. Beware not to use the term insidious in ENT. Not much of the disease conditions in ENT are using, you could not use the term insidious in onset. Okay. So nasal obstruction.